So a very good evening to everyone from India. As president of Chandigarh Ophthalmogical Society, it's an honor for our society to be invited to this conference. And I extend my thanks to Dr. Amri and his team who prepared such a great academic event with the best of speakers from all over the world. And we are happy for this wonderful collaboration with the Al-Qasmi Society. So without wasting much time, I'll just introduce our moderator. She's Dr. Diksha Katoj, and she's an associate professor at PGI and also the joint secretary of Chandigarh Ophthalmological Society. Her keen area of interest is the retinopathy of prematurity. I'll request Dr. Diksha to start the proceedings. Thank you.
A very good evening to all, and thank you, Jasprit sir, for the introduction. We would start right away with the session with the first talk from Professor Pandav. Professor S.S. Pandav is the current head of the department at the Advanced Eye Center, Department of Ophthalmology of the Postgraduate Institute of Medical Education and Research in Chandigarh, that's north of India. He is also the president of the Glaucoma Society of India. He was also a visiting professor at the University of Melbourne, Australia. He is an eminent speaker, an eminent teacher in the field of glaucoma, and it's our honor to have you, sir. And sir would be delivering a talk on handling the challenges in glaucoma practice during COVID times.
Thank you, Dr. Diksha, and thank you, QUIC and COS for giving this opportunity. Can you see my slides?
Yes, sir, we can see your slides. We can hear you.
I have no financial interest to declare. I'll be talking about handling the challenges in glaucoma practice during COVID times. The COVID has taken its toll, and almost half of the world population has been infected in the last 2 years or so, and it has left close to 6 million people dead. It has severely impacted healthcare delivery system all over the world, and this is the study from the Western world, where almost more than 40% of the US adults, they actually delayed their or avoided medical care during the pandemic because of the fear of getting infected. And 12% of them were actually emergencies or urgent healthcare problems which were delayed. So they would have their own consequences. Glaucoma care has suffered too, and this is data from the South India. And they found that close to 60% of glaucoma patients, they were not compliant to their medical therapy during the pandemic. And as we know, the compliance is very important for any chronic disease, especially for glaucoma, where we need to maintain target intraocular pressure, otherwise glaucoma could progress. And the main cause for non-compliance was non-availability of medications. So the lockdowns, the repeated and prolonged lockdowns, restrictions in traveling, and disruption of the supply chains, etc., led to its consequences, and many of these patients actually went off treatment during the pandemic. So this is a story of a 12-year-old female diagnosed with juvenile open-angle glaucoma. She was with us for the last couple of 5-6 years and had undergone trabeculectomy with mitomycin C in 2016. As you can see in the discs below, there's a significant disc damage at the superior as well as the inferior pole of the disc, both eyes. And also there's a corresponding visual field defect, the biarcuate scotoma in the left eye more than the right eye. The pressure was very well controlled after trabeculectomy, as you can see, for about 4 years or so. And that was the time when pandemic happened and the patient was lost to follow. And when she returned after 2 years, you can see her pressures were high, 42, 32 millimeters of mercury. The blebs are scarred, and she was already been started on some anti-glaucoma medication recently. As you can see from the visual fields, her fields have deteriorated significantly in the last 2 years' time. So there was a progression. IOP could not be controlled with medicines alone. So we did surgery, and fortunately we were able to open this scarred blebs using Aventino bleb revision, which worked for her, and the pressure came down to about 10 or 12 millimeters of mercury. But it's still a short follow-up, and we are hoping that the pressure would remain controlled over a period of time. So that was one example where the glaucoma care was affected. And this another patient, 23 years old female, she's had myopia, she had retinal detachment, had already undergone plasma vitrectomy. As you can see in the pictures, she had a shallow AC, the lens is opaque, this, and it's swollen, as is seen on the OCT image, which shows a very thick lens, and you can always see a little bit of hint that there might be disruption of the pressure lens capsule already happening. To make things more difficult, she was pregnant 22 weeks, and she was also COVID positive. Now, she needed urgent care, but because of her COVID positive situation, and so she needed to be operated in a COVID positive in a COVID hospital. So that would take a little time. So treatment was a little difficult and had difficulty in scheduling her. And also because of her pregnancy, we were limited in giving what we could, give her to control intraocular pressure. And ultrasound revealed that there was already a retinal detachment which had reoccurred, so that made things even worse. So we tried to control his brimonidine beta blockers and topical drops, but the pressure was not really well controlled. But eventually we could manage to phacoaspirate her. There was a posterior capsular rent, and we left the eye and referred for the retina surgery after the pressure was controlled following the removal of the lens, fortunately for her. So that's another example of how things could go wrong. We have seen many challenges during the COVID-19, and we continue to see challenges actually, even if the COVID cases are declining now. We have seen more complicated cases during this time as compared to earlier when we used to see glaucoma patients. I expect that there's going to be a backlog of glaucoma patients who have not visited eye hospitals, and they need to be basically diagnosed and treated appropriately. We also expect that in the coming days, we might see more advanced disease because of either delayed diagnosis or because of unavailability or disruption in the treatment plans. And but more difficult and important at this point of time is now to get patients back to the clinics, because there's long delays in their follow-ups, and we need to bring these patients back. We need to identify these people and start appropriate treatment whenever required. So we need to have more efficient trials, basically, because teleconsultation we are still using for to connect with these patients, and we need to have a little better, more efficient way of triaging these patients to identify people who are already at risk and or who are at more of risk of blindness because of glaucoma, and get them back into the clinics. So still the challenges are mounting, and we'll see more and more of these these type of situations. So thank you very much for letting me participate in this webinar. Thank you.
Thank you, sir, for an excellent talk, and for bringing out the challenges that this COVID lockdown has brought about to the management of patients, and especially in the glaucoma practice. I think this is something which not only the developing countries, but has been faced by most of even the developed countries across the world. And you highlighted the point that it is very, very important now that we get back to identifying and how we can bring back these patients for follow-ups and be effective in our teleconsultations. Thank you, sir. So we move on now. So we have another eminent glaucoma faculty, Professor Sushmita Kaushik. She is Professor of Ophthalmology, again at the Advanced Eye Center at the Postgraduate Institute of Medical Education and Research in Chandigarh. She's the founder secretary of the Indian Pediatric Glaucoma Society. She's the vice president of Chandigarh Ophthalmological Society and former secretary of the Glaucoma Society of India. And her area of interest and her special interest is in the field of pediatric glaucoma. So ma'am will be talking about avoiding EUA in the times of COVID. Welcome, ma'am.
Thank you. Thank you, Dr. Diksha, and thank you, Al-Qasimi, for the opportunity. And it's my pleasure to share this. Are my slides visible now?
Yes, ma'am. Yes, ma'am.
Okay, I can't make it full screen somehow. It's not, full screen isn't happening. What do I do?
You left down to the full screen
I
mode.
know. Nothing is happening. Can you see my arrow moving all over the place?
Yes, yes, we can see it. We can see it.
Yeah, but nothing is
Maybe
happening.
from the bottom panel.
Yeah, I know. See? This is not
Uh-huh.
happening. This is not
So
happening.
maybe
Yeah,
you can
but-
unshare and share
Yeah,
again.
unshare and share again. I'll make it full screen first. Sorry.
Yeah.
Sorry about that. Yeah. Let me see. Yeah. Okay. And then I go back to Zoom. All right. Let me see now. Is that all right? Is it okay now?
Yes, ma'am.
Yes, okay. Right. Thank you so much. And I'll be talking about how to avoid examination under anesthesia in terms of times of COVID. GA itself was considered to be a higher risk because of the risk of respiratory transmission. So even the general anesthesia team had their reservations in doing too many. Right. So there are no financial disclosures, and we've taken informed consent from parents of the babies to use their clinical photographs. So we presume congenital glaucoma means they would have undergone surgery. And that's something that can't wait until COVID is done. So we did carry on with our surgical management. But the question was, does it have to mean multiple EUAs? And once surgery is done, what next? And in these COVID times, how safe is it to call them back repeatedly? And when they do, what is it that we look for? And how to evaluate? Can we really do away with the EUA? Can we just use sedation? And what disease progressors can we use despite controlled IOP? Can we use the cornea and the axial length, for instance, to know whether the disease is stable or not? So one thing that we started was bilateral simultaneous surgery. That's the number one change that COVID time has given us. We never used to do simultaneous surgery for glaucoma in these babies, but we realized it was logical and it made so much of sense. And for logistics, it really was a boon for the babies. So, and if it's bilateral, we didn't make them stay and prolong the hospital stay. We would open the patch 4 to 6 hours after GA, and we still do that now. So we realize the babies are also happier and much clearer. And you can see this hazy cornea has become clear in just about 4 hours after GA. We look for the cornea, the anterior chamber, and the high femur, and it helps us to better plan EUA for the eyes if required. So they can be sent back on the same day, almost a daycare surgery, because especially with ab interno, there's not much that goes wrong with these children anyway. So the most important thing we've learned to look for is a child's comfort, and the mother's feedback is very important. So if the mother says that the kid is happy and is not in pain, so this is a child pre-operatively and operated during COVID time, and even 6 weeks later, the kid was happy enough to look at me through the slit lamp. And we look at corneal clarity, we look at intraocular pressures if possible. And the one thing that is in addition very much is the axial length. So the IOP has surrogates in the cornea and the axial length. The eye care is increasingly being used, and GAT in awake children is the most accurate method, but rebound overestimates the IOP. So we're okay with it. So if the rebound tonometer gives us IOPs of 16, 18, we're okay in children because we know that it's overestimated. And it also increases with increasing CCT and IOP. But it's good that it's overestimated because then it makes us safe when it happens. The next thing is even if the IOP is normal, we have to realize that the children have elastic eyes. So the axial length plotting along a normative database is something that we've introduced in our practice, and it has become commonplace for us. For instance, this preterm baby had ROP, both eyes LIO was done, and left eye underwent lens sparing vitrectomy. But then she had a very rapidly progressing ophthalmos. The IOP remained okay. That's the funny part. But the eye enlarged because it's so elastic. So she, of course, underwent surgery. And this is the same baby. So this is how she starts off. It goes up there. We do a combined trab with trab. And actually, the axial length straightens out. So this baby hasn't had any EUA because we can see the cornea has cleared, the axial length has stabilized, and we assume that the disease is not progressing. But then still, when should we think of an EOA? One is, of course, when the IOP is high and the axial length is continuously rising. But more importantly, if you're doing ab interno surgery, then be very, very sure of suture removal. So sutures have to be removed in the next 3 months in a child because that gets to be very dangerous and it's an absolute indication. Then, of course, there is recognition of the risks of repeated general anesthesia. We consider sedation. We've published this on intranasal dexmedetomidine. That's also helped us avoid EUA. In the interest of time, I'll skip this video, but it just shows that the child can be easily examined with in just the preoperative room with intranasal dexmedetomidine. Beyond the IOP, we don't have to forget vision in these children. You don't need UA to do that. And there's so much beyond the intraocular pressure, because with these babies, we're in the business of vision. For instance, a unilateral ophthalmos with high myopia, we either give contact lenses or we also do clear lens extractions at time for something like minus 25 or 26 diopters myopia. And here is the kid about 4 years later with just an IOL in this one eye. So to summarize, it's lifelong. It can manifest in myriad forms. Ensuring good vision is our goal, and we need to hold these children's hands, EUA or non-EUA. Thank you. Thank you very much again for having me.
Thank you, ma'am. Thank you for another wonderful talk on managing pediatric glaucoma, and more importantly about how you can monitor without doing an UA. For example, just monitoring on the progression of the axial lengths. That's one. And probably these are one of the important indications for doing a bilateral simultaneous surgery. Are there any comments from the panel? Especially, I would like to invite Pandav sir for any comments on this talk. Okay, so we maybe we can go ahead. Jaspreet sir.
Yeah.
Okay. So our next talk is by Professor Jaspreet Sukija. We just have the introduction to sir. He's the president of the Chandigarh Ophthalmological Society. He's one of the professors of pediatric ophthalmology, and his special interest also includes neuro-ophthalmology, for which he has been trained in London under Dr. Gordon Plant. And sir will be giving his talk on improvisations in pediatric cataract surgery.
Thank you, Dr. Diksha, for the introduction. I would be speaking on some of the improvisations that have been made recently in the COVID times, and how they could help us in the future. So what are the burning issues in pediatric cataract surgery? Basically, it's your IOL power calculation, how much target refraction you want. Then the most important problem intraoperatively is pupillary dilatation. And because there's a risk of pupillary constriction in children during your surgical procedures. Visual axis obscuration, what we see when we follow up these children, would require additional surgery. And considering all the COVID times, probably an additional surgery would mean a lot of logistic issues for the patient also, and the myopic shift which comes up over a period of time. So first, coming to the IOL power calculation, of course, the gold standard is what we are using is you should be the IOL master, but in young children who don't fixate, we use the A-scan for calculating the axial length. For keratometry, it becomes very difficult. If the child is really moving around his or her eyes, it's very difficult to have an accurate reading. So we use a handheld keratometry if the child is sleeping, and we do reconfirm it with the anterior segment OCT, which just requires maybe just a few seconds, maybe 3 or 4 seconds of fixation, and the machine takes the reading. So these are some of the things which we have been using in the recent past. The formula what we're using is SRKT, and the target refraction definitely, I mean, it's not those 8 diopters or 7 diopters what we use in an infant. We're targeting +4 if the child is above 6 months of age, and by 4 years we try to keep the child emmetropic. Coming to the second thing, which is pupillary dilatation. So in these COVID times, I mean, we don't know when the patient is taken up and the child crying, if he's had a feed or anything. So all these issues come up. So in pediatric cataract surgery, the success largely depends upon the adequacy and sustenance of pupillary dilatation. That would be for an adult also. But in children, it becomes more pronounced because the dilator muscle is underdeveloped as compared to the sphincter pupillae. And intraoperative meiosis poses another challenge. So conventionally, we would use topical mydriatics, but the issues are that the dosing is universal. Yes, we need to dilute them in infants. There could be associated side effects. Allergy is known to some of these drugs. They are toxic to the epithelium sometimes. Absorption in a crying and uncooperative child becomes really difficult sometimes, and it has to cross the corneal barrier. Then you use 3 or 4 type of drop preparations. All these issues just add up to what the parents have to do for the little child. So all these could be done away with by using this intracameral solution which achieves rapid mydriasis. It consists of tropicamide, phenylephrine, and lidocaine. So it's an intracameral anesthetic mydriatic solution, which we used in these children. And if you see this one in a child where we taken up for surgery and the pupil is not dilated with the drops, but what we used was the intracameral solution. So we've injected that, and you can see here the pupil is dilating, and when you're doing the irrigation aspiration, you see it's a well-dilated pupil, almost reaching up to the limbus. We haven't used any drops in that. And during this irrigation aspiration, which is the most crucial time when the pupil comes down because of the aspiration, we are having a nicely dilated taut pupil, and there's no risk of the iris margin coming into the ports of the aspiration cannula. So that's the beauty of this intracameral solution, which we can do, and we can do away with the topical drops. So in our study, we had a diameter of 6 millimeter. The pupillary diameter was achieved in majority, and it was sustained effect till the end of surgery without any systemic side effects. And this was published in the European Journal of Ophthalmology. Probably the idea was so good, it was accepted. So 3rd March, we submitted it, and 9th March, it was accepted. So within 6 days, probably, we were fortunate to have it accepted in 6 days. So the advantages are the targeted drug delivery, no ocular surface toxicity or side effects. In COVID times, when there's uncertainty when the patient is taken up, it's always good to have them handy. Prior gonioscopy is possible in these undilated pupil. It can be used in those allergic to atropine or cyclopentolate, and of course, cost-effective for just a single ampule what you're using. The other important thing is preventing visual axis obscuration. So conventionally, we would use a primary posterior capsulotomy, anterior vitrectomy, and put the IOL in the back. But here, what we did was we did not perform an anterior vitrectomy and put the optic behind the posterior capsule. So the haptic was in the back, and the optic was behind the posterior capsule. So the problem in conventional is issues come up in the conventional surgery are when you're doing vitrectomy with IOL in the back, is that the rexus has to be fairly appropriately sized, both the anterior and posterior. We'd still have a visual axis opacification rate of 30 to 40% with increased inflammation in a conventional pediatric cataract surgery. Plus, there are issues with vitrectomy, and is the back big enough to accommodate the IOL, especially in infants? That is still questionable. So issues with vitrectomy, if we perform the optic capture and we do not do a vitrectomy, that's the newer method what we have, the anterior face remains, anterior vitreous face remains intact. Obviously, it's a barrier. We are in a growing child, we are still not aware what the issues could be, how much vitrectomy is adequate, because we still do have visual axis obscuration after anterior vitrectomy. So that still has to be found out what is adequate. You could have complications when you're just cutting the vitreous, like enlargement of PPC or the vitreous coming into the anterior chamber. So this is just to show you some of the videos. I mean, what we had, this was just one patient where we, sorry. Yeah. So this is the patient, I'll go forward. So we did an anterior rexis, and the important thing is when you're doing a posterior rexis, it has to be a fairly large rexis, because you want the IOL the optic to go behind the posterior capsule. So the IOL goes into the back, and then you put one part of the optic behind the posterior capsule. You can see this oblong thing, and you're pushing the other part behind the posterior capsule. So the haptic is in the back, no vitrectomy has been done, and you can see the oblong posterior rexis, which shows that the optic is behind the posterior capsule. Here it's much clearer here. This oblong thing shows that it's behind the posterior capsule and a round rexis. So this was the conventional, this was some modification what we did in the routine pediatric surgery, but then we started using them in patients with complicated cataract as well, like lenticonus, where obviously the posterior capsule is very weak, and so you could have issues sometimes when putting the IOL in the bag, or it might extend. So with an optic capture, probably posterior optic capture, these issues are taken care of, because whatever the size of the posterior rex is, probably not a large size, but even if it's irregular, you can still put the optic behind the posterior capsule. And this is what we put it in the bag, and we're pushing the optic behind the posterior capsule. So this is lenticonus, in which we did the posterior optic capture. You can see the oblong posterior margins. And of course, another complicated case was persistent fetal vasculature. I'll just go forward. You could just see the wing there, and we put the IOL in the bag. Of course, we did the posterior rexis with we used a cutter for doing the posterior rexis, and we are prolapsing the optic behind the margin of the posterior capsule, first just one half and then the other half. So what we can see here is an oblong posterior rhexis and a nice anterior rhexis. So the optic is behind the posterior capsule and the haptics are in the bag. No anterior vitrectomy was done. So just to show you some of the pictures, this is the early post-op picture of an infant where we did the capture. You have an oblong posterior rhexis and a nice anterior circular rhexis, and soon we'll have a somatic ring formation. This will be an older child. And if you see at 5 years follow-up, what we have in our study, the same eye, both the eyes of the same patient, in which we put the IOL in the bag with anterior vitrectomy, and the other eye, we did an optic capture. We still, at 5 years, there is epithelial cell proliferation, and which are coming into the visual axis, but the one with the optic capture has a nice ring, and all the epithelial cells, they are all sequestered in the bag without anything reaching to the visual axis. So these are some of the papers what we published. The recent one where we did optic capture in patients with difficult cases of pediatric cataract. So I'd like to conclude here by saying that IOL implantation is safe in those over 6 months of age. One has to weigh the risk-benefit ratio in the Indian context. However, there's no agreement on which formula you can use when calculating IOL power. One should modify the technique as indicated. And this intracameral mydriatic which has come is a game changer for pupillary dilation. It has made things much easier and much safer. And posterior optic capture is no doubt a promising technique for IOL implantation in children. Thank you so much for your attention.
Thank you, sir. Indeed, a wonderful presentation. I just have a little small question for you, like your experience with the intracameral mydriatic in the literature that you've published. So you've used it around 4 years. So as you are gaining more experience, would you recommend it even children less than that, or would there be a cutoff age where you would recommend that you use it only above that age?
Thank you for that question. Yeah, we've used it in infants. So we had a couple of infants in that study as well. It is no doubt, we're still doing a randomized study to answer that question, where you could use it. But yes, the older the child, the better is the response to the intracameral solution.
Thank you, sir. And do you now routinely just do the posterior optic capture, or are there any situations where you still do the conventional surgery?
Yeah, the posterior optic capture is no doubt the preferred mode. But yes, in those, especially when you have membranous cataracts or you have where the posterior capsule is thick and the chance of tear are there, probably I would not do a capture in those patients.
And Dr. Subina, she had a question for you that what would be your preferred technique in eyes with a persistent fetal vasculature?
So it really depends. I mean, if it's just an anterior PFV, probably you could implant an IOL. But if it's a florid PFV, I would really not implant an IOL in those cases because they have a lot of inflammation, secondary glaucoma, and all those issues, and the hemorrhage and all. So yes, anterior PFV. I mean, in those with you can say mild PFVs, IOL implantation is a good option. And depending upon the size of the rhexis where it is attached, you could because you will have to cut the stalk. Probably you would end up doing some vitrectomy. So wherever is a place, probably I would implant the IOL in the bag in these children. But yes, if it's a very mild, I would definitely go in for an posterior optic capture.
Thank you, sir. Thank you. Any other comments from our panelists? Thank you. If there are any questions from the audience, you may just put it in the chat box or the Q&A, and we'll take it at the end of our session. So our next speaker is Professor Jain. Unfortunately, he and Dr. Chintan were not able to connect today. So the next speaker is Professor Amit Gupta. Sir is a professor of ophthalmology again at the Advanced Eye Center, PGIMER, Chandigarh. He has a special interest in corneal diseases and he has vast experience in refractive surgery. He is also the Senior Vice President of the Chandigarh Ophthalmological Society and also the Honorary Secretary of the Eye Bank Society of Chandigarh. So Professor Amit will be talking on the SMILE lenticule for corneal perforations. Desperate times call for desperate measures. Welcome, sir.
Well, thank you. And I would like to thank the Chandigarh Ophthalmological Society as well as the organizers of the QOIC 2022 for the kind invitation. Yeah. So I'll be talking about the use of SMILE lenticule for corneal perforations. Now, so corneal perforations are an emergency and a challenge. No matter what the situation is, they may be infective or non-infective, but they have to be tackled. And the usual practice is to do a corneal transplant, and we should use the highest quality of cornea available so that we are able to do the best for these cases, and they are able to regain some useful vision. But the global COVID led to an unprecedented challenge for in eye banking. There was a precipitous drop in the number of eyes collected, and we soon ran out of all the stocks that we had stored. And there was also a considerable drop in the utilization rate. So what we were left with sometimes is the presence of an NTS staphyloma or a painful blind eye, just because we could not perform the corneal transplantation in time in these patients. Now, if we have a quick look at how corneal perforations should be managed, usually smaller perforations can be managed with tissue adhesives, and there are also a use of biologic tissue, including conjunctival flap, amniotic membrane, Tenon's patch graft, sterile patch graft, and of course the cornea. So the COVID time challenges, we are a major tertiary level hospital, and from all over patients were coming with different types of perforations, and we really didn't know, and we didn't have enough resources to help them out. Some of the patients we did try, like this patient, he was PL negative in one eye, and this was the other eye. And what we did for this patient is we used a bit of sclera because there was no corneal tissue available. And he did quite well, actually, and he regained a vision of 6/6, and this now has more than 1 year of follow-up. Another patient who presented when there were no eyes available, and I had to do a scleral lamellar graft. But there's a lot of problems with these non-healing epithelial defects, vascularization, and all of these lead to some kind of a problem in rehabilitating these patients later on. So we looked at something else. We know that the smile surgery or the small incision lenticular extraction, so that's used to correct myopia, and it gives us this lenticule, and this lenticule is a precious bit of tissue that we decided to use in these patients of corneal perforations. So this was a 35-year-old man, and he presented with this perforation, and we did a cyanoacrylate glue assisted smile tectonic lenticule application and AC reformation. So important thing is you have to create the bed very carefully, and you have to deepithelize it and have sharp borders. The sizing has to be done precisely so that, and this stromal tissue will then just get incorporated as the patient heals. So sometimes the results can be really gratifying in these patients. So this patient, the anti-segment OCT shows how well the stromal tissue is actually incorporated. You can't even make out from the recipient cornea. And the anti-segment, the intraoperative OCT is an invaluable tool in these patients. While we are shaping the bed, it tells us at what depth we are going to avoid an inadvertent perforation, and we can see, we size it, and a lot of studies have shown that actually suturing may be preferable. They don't really do so well with fibrin glue because of so much of inflammation and sloughing of the tissue. So this patient did very well, and we can see right on the table with the intraoperative OCT that the corneal thickness has been restored by the smile lenticule. The advantages of the corneal stromal lenticule are that it's safe, it is efficient, it is inexpensive, it's an acellular tissue, so there's no rejection actually. It does not require an eye bank setup. It's a biological tissue, so there's less reaction than say a glue or a cyanoacrylate adhesive. In the literature, there are some few studies which have published regarding the use of smile lenticule, and they have also reported good results, least complications, no cases of rejection or recurrence of infection. There are some limitations that there's a narrow range of diameter of corneal lenticule because it cannot go more than 6 or 6.6 millimeters. Therefore, it's not very suitable for large perforations. There's a limited thickness of most corneal lenticules, maybe 100 and 140 microns, which may require overlapping of multiple lenticules, or maybe combining it with the amniotic membrane for best results. And tissue has to be, of course, handled very carefully. The purpose of just making this table is just to show that people have used different kinds of media and different kinds of methods for storage. We are still not there yet as to how to use it, the BSS and Optisol, normal saline, and many people have just sutured it. A few of them have used, fibrin glue, Optisol, phosphate buffered saline solution. And so a few tips for people who are listening to this talk, who might like to use the SMILE lenticule. What we are doing at the PGI Chandigarh, we are using the donor SMILE lenticule from patients of myopia correction more than 5 diopters. So that gives us something around 100 microns or 5.5 diopters or so. So the lenticule we are storing in cortisol media and an alicot, and it's stored cryopreserved at -80 degrees. Thanks to COVID, we could store and even use the lenticules after 4 months with very nice results. So to conclude, there exists a significant future potential for SMILE lenticule to be used as a biological tissue. I think it's just underexplored as yet, and it can be used to maintain the ocular integrity, especially in the smaller perforations and corneal thinning. And thus, it may avert the need for therapeutic keratoplasty, or also give the patient time so that we get good optical quality tissue for that and prevent all complications. Thank you very much.
Thank you, sir, for another wonderful talk. In the interest of time, we will now move on. So our next talk is by Professor Subina Narang. She is a professor of ophthalmology at the Government Medical College and Chandigarh, Medical College and Hospital at Chandigarh, and her area of interest is retinopathy of prematurity and medical and surgical retina. She will be talking on biomarkers of treatable ROP in serum and urine of neonates. Welcome, Dr. Subina.
Thank you, Dr. Diksha. Can you hear me?
Yes, we can hear you. Can you please share your screen?
Oh, I did share it. Fine, one sec. Thank you, Chandigarh Ophthalmic Society and Al-Qasimi Society for giving me this opportunity to speak in this wonderful session of what I did new in 2021. Well, everything was under lockdown practically last year. The only thing which we were continuing was retinopathy of prematurity and emergency cases. So I'll be presenting the systemic biomarkers which we evaluated during this time. India has the highest number of preterm babies, and huge birth cohort of India translates into substantial number of babies for ROP screening, and only 15% of these babies go on to develop ROP, requiring treatment. And India has limited number of trained doctors in hospital where ROP management is done. With the coming in of this lockdown, COVID times, the lockdown was a big challenge for timely screening and treatment of ROP babies from surrounding areas to our hospital. There is need of the was at that time to evaluate systemic biomarkers of treatable ROP, which is detected in early course of the disease, and timely referral of these babies at risk of developing ROPs to hospitals and doctors where facility for management of ROP exists. And the new recommendation added on to our burden of management of these babies. GMCH protocol for ROP screening at that time was screening after rat test of mother as well as baby at every visit, and screening was done in batches of 6 to 7 per hour so that social distancing could be maintained. And doctors were to wear RP kit, proper hand hygiene, and neonate to be wrapped in the sheets. All those added to the burden for screening these babies. So to evaluate the systemic biomarkers for progression of treatable ROP, we just looked at the literature. Neonatal inflammation has been identified as a key modulator in ROP. There are various pro-inflammatory cytokines associated with ROP like interleukin 6, 8, interleukin 12, interferon gamma, and resto-endothelial growth factor, etc. So we carried out this study with the aim to determine whether interleukin 6, interleukin 8, or VEGF levels in serum or urine of these preterm babies at the time of first screening examination could predict the development of treatable ROP in these babies, so that we could follow up them accordingly. To correlate these biomarkers with severity of ROP was our secondary aim. Inborn preterm babies who were screened for ROP were birth weight less than 2,000 grams and gestational age less than 34 weeks, which is the Neonatology Forum guidelines for screening of babies. ROP screening was done using indirect ophthalmoscope and documentation was done, if required, using RedCam. At initial screening visit, the blood and urine samples were collected as a part of routine sampling, and they were stored at -80°C for later processing. Babies were screened and followed up till ROP development or complete vascularization till ora serrata or till 45 weeks of postmenstrual age. At 10 months follow-up, babies were divided into Group A. Those were the babies who developed treatable ROP, and Group B, those were the controls, the babies in whom the ROP had either regressed or who did not go on to develop ROP. And the evaluation of interleukins and VEGF levels, they were done by solid phase sandwich ELISA technique. We had 35 babies who were in Group A, that means who were having ROP, and there were 36 babies who were age matched and they were not having ROP, or they had regression of ROP. The evaluation of biomarkers showed that interleukin-8 levels were significantly higher in cases as compared to the controls. Notably, there was significant overlap between the values, and it was seen that area under the ROP curve demonstrated suboptimal discriminating ability. And once we did intercorrelation within the biomarkers, it was seen that interleukin-6 and interleukin-8 did correlate with each other. For every 1 unit increase in interleukin-6 levels in the blood, there was increase in interleukin-8 levels by 2.32 units. Similarly, interleukin-8 in the blood did correlate with interleukin-6 of the urine, and interleukin-8 of the urine did correlate with VEGF levels in the urine. And if we did correlation of these biomarkers to the severity of ROP, it was seen that severer stage of ROP and the worst zone of ROP was associated with higher levels of interleukin-6 and interleukin-8. And if we compare the results of our study with the available literature, it has been seen that there's one study which talks about the inflammatory biomarkers interleukin-6 and 8 associated with the progression of ROP. But this evaluation was done from the amniotic fluid in the antenatal period. In the present study, what we have used is blood and urine samples, which is easily collected as a part of routine sampling procedure. And interleukin-8 at the initial ROP screening was significantly higher in the babies who developed type 1 ROP or treatable ROP. Concluding, interleukin-8 levels are significantly raised in ROP requiring treatment. Inflammation definitely has a role in ROP pathogenesis. The level of interleukin-8 and interleukin-6 was higher in severer forms of ROP, but did not reach statistical significance. Now we propose further studies which need to be done to establish the role of interleukin-8 in treatable ROP and immune targeting of interleukin-8 by anti-interleukin-8 cytokines, which could be interleukin-10 or cholecalciferol or steroids, which are known to be anti-interleukin-8 early in the life, so that could be preventive for the development of treatable ROP. Thank you.
Thank you, Dr. Subina. That was a very interesting talk on biomarkers and how they can be used in future for as targets. I mean, to prevent, I mean, inflammation and all these things. I mean, food for thought for future research, definitely. So with that, I'll now invite our Joint Secretary, Dr. Diksha Katoch, who is a faculty at PGI, and she would be speaking on ROP as well. And she has a, so her key area of interest is ROP, and she's done a lot of work on ROP, even in the later stages, like the surgeries for these little neonates, which is quite a challenge. So I'll now invite Dr. Diksha to give her talk.
Thank you, sir. I'll just share my screen. Is my screen visible?
Yes.
So Thank you, Al-Qasimi Society and Chandigarh Ophthalmological Society for the opportunity. And continuing with the theme of ROP, I will be discussing the management of posterior pole rhegmatogenous retinal detachment in a preterm infant with aggressive ROP. As we all know, rhegmatogenous retinal detachment is itself a little rare in ROP, and most commonly the detachments are associated are tractional detachment. So this was a female preterm infant who was born at 31 weeks of gestation and with a birth weight of 1,800 grams to a mother who had active COVID infection. And after birth, the child had a history of respiratory distress, suspected bronchopulmonary dysplasia, and jaundice. Our ROP screening done elsewhere 3 weeks after birth revealed a diagnosis of aggressive ROP in zone 1 with plus, for which the infant was treated with laser photocoagulation followed by intravitreal ranibizumab at another center. 1 week post-procedure, the treating physician noticed a retinal break in one of the eye, and the child was referred to us. So these are the RETCAM photographs of the infant at presentation. We can see both the eyes had a persistent avascular retina beyond zone 1, while the right eye had a large, full thickness retinal break, almost the size of the disc diameter and almost at the edge of the zone 1. Why it happened? It was probably related to the pressure necrosis of the jet of the injection, because we did not see any track which was suggestive of a perforation. So intuitively, the first thing we did was to do a laser photocoagulation of the retinal break. Since there was already presence of a shallow subretinal fluid, we thought that if the laser worked, then this would be great. And 3 days later, we did see some uptake coming up in the around the edges of the retinal break, in fact, all around, and we thought that probably this would be enough. However, that was not to be, and 2 weeks later, we saw that there was presence of subretinal fluid involving the entire posterior pole, and the inferior edge of the break was lifted and was also confirmed on the OCT. So how do we manage this case? The child required surgery, but scleral buckling would be difficult because of the very posterior location of the retinal break, and vitrectomy has its own challenges. It would require PVD induction, which is itself challenging in these infants, and also require long-term internal tamponade, which we know most of the times in these situations would be silicone oil, and it has its own risks of cataract and glaucoma. So we decided to proceed with a radial buccal element, and in this case, we used a 505 sponge. So after doing a peritomy and the tagging of the recti muscles, indirect ophthalmoscopy was done, and the break was localized. We used a small segment of the 240 band, that is 2.5 millimeters on either edge of the sponge to secure it. And then a 505 sponge was inserted below the band, and it was secured with vertical 50 dacron sutures, first passed at the posterior edge, and this was followed by a suture at the anterior limit of the radial sponge. Temporary knots were tied for the 50 dacron. The break was almost 13 millimeters posterior to the limbus. We did an indirect ophthalmoscopy after the first suture, and we realized that the most posterior edge of the break was still not supported. So another suture was passed with great difficulty posterior to the original vertical mattress suture, and it was also secured. After this, a repeat indirect ophthalmoscopy confirmed that the posterior most edge of the break was supported. So then the anterior edge of the radial sponge was secured with the 50 dacron suture, and the extra sponge was trimmed. This was followed by tying of the 240 band sutures, one suture on either side. No attempt was made to drain the subretinal fluid because the peripheral retina was all lasered and there was no fluid in the periphery. And the fluid was located very, very posterior, and it would have been difficult to drain such a posteriorly located fluid. This was followed by conjunctival closure. So gradually over a period of next 3 weeks, the subretinal fluid absorbed, and we can see on OCT, the indent provided by the radial sponge. And these are the photographs following surgery. 6 weeks later, we went ahead and explanted the radial sponge once the retina was attached. So to conclude, retinal breaks have been very rarely reported after anti-VEGF therapy for ROP. Most of the retinal detachments in ROP are tractional, and management of a rhegmatogenous retinal detachment in acute ROP is challenging because of the difficulty in PVD induction and risks of long-term intraocular tamponade in infant eyes. Despite advances in vitrectomy, scleral buckling still remains a good alternative in certain challenging situations in ROP. Thank you for patient hearing.
That was no doubt a challenging surgery, and only experts can do that in such a small eye. And so there are a few questions, but I think we can take it up at the end. A few discussion points. I think Dr. Diksha, you can invite the next speaker before we go on to the question.
Yes. Okay, thank you, sir. And in the end, we have Dr. R.K. Bansal, who's also faculty at the Government Medical College and Hospital of Chandigarh. He's a member of National Academy of Medical Sciences and currently runs his own clinical practice in the name of Bansal Eye and Retina Center at Chandigarh. Welcome, sir, and we would like to invite you for your talk on bilateral simultaneous cataract surgery in adults.
Thank you, Dr. Diksha. It's coming now?
Yes, sir.
Yeah,
yes,
okay.
yes, absolutely. Please go ahead.
Thank you, Dr. Diksha and Chandigarh Ophthalmological Society for giving me this opportunity. I shall be talking about bilateral simultaneous cataract surgery in adults. So what are the different advantages and disadvantages? I have no financial disclosures for this talk. Whenever we face a dilemma, when a patient comes with bilateral cataract, which is quite significant, then we have two options, either to do a surgery with a gap of about 4 to 6 weeks on the second eye, or one can plan immediate sequential bilateral surgery. The concept of bilateral cataract surgery started somewhere in 1952 when the intracapsular surgery was being done. And then later phacoemulsification started somewhere in 1996, where the people started doing bilateral cataract surgery with biphacoemulsification. And later some other countries also followed. And we have some reports from India as well, where they have done some bilateral cataract surgery. Now we know, if we go into the history of bilateral surgery, we know extraocular surgeries, a number of extraocular procedures are being done, like ptosis, pterygium, strabismus, LASIK, and SMILE. They are being done on both the eyes. But when it comes to intraocular surgery, we have a little fear in mind, but there are reports where people have done trabeculectomy, the ICLs, vitrectomies, and pediatric cataract surgery. Of course, I've been doing earlier also in bilateral eyes and intravitreal injections. We know the procedures are being done. I'll show a small video how we can go about the second eye. Because there is a paucity of time, I will just skip some parts of the video. This was a patient who opted for bilateral cataract surgery. The patient is being implanted with a Synergy intraocular lens implant. And once we finish with the one eye, then just want to show how we go about the surgery on the other eye. So these are the steps are very important. The surgeon is ready with the new gown and the gloves, and the patient is also ready for the second eye surgery. And you can notice that all the instruments which were used for the first surgery are not there. So we are going to open a new set of instruments with all the new drapings for the patient as well as for the trolley. So that's very important, but that we use both the eyes as a separate surgeries. So this is how we go about the second eye surgery. So all the instruments are new for this patient for the second eye. So then we go on to the second eye, and one can easily go ahead with the phacoemulsification and do the second eye. Now, what are the different advantages? The advantages can be to the patient as well as to the hospital. For the patient, there's a less number of visits. The patient gets early rehabilitation. It's become economic because patient has to make less number of visits. And usually the no anisometropia will be there between the two surgeries because you are calculating the IOL power based on the calculations, so that there is no anisometropia between the two eyes. And also patient gets one pair of glasses after the surgery. To the hospital, there is advantage that patient needs only one preoperative visit. All the assessments, investigations are done at one time, only one admission, and there is an efficient use of the theater. And especially when we talk about surgery in children, the stereopsis is not disrupted because you are doing both the eyes together. So all these patients, the chances of amblyopia will be much less, especially in children. But some of the disadvantages which are being talked about bilateral simultaneous cataract surgery is the risk of endophthalmitis. Of course, the risk is there. I'll show you some of the studies from the literature which say the risk is just in the mind, but it really doesn't occur. The TAS syndrome, if you're using the same viscoelastics and the fluids in the eye, so one has to avoid and use separate set of all the equipment, all the things which one has to use for the cataract surgery. The another disadvantage which I feel is more important for this is that refractive correction. may not be possible in the other eye, because if you are getting some amount of either myopia or hypermetropia, it is possible to correct in the other eye if you are using a separate set of cataract surgeries. Then risk of cystoid macular edema, the PC and corneal edema, these are just theoretical risk, but not there in the real sense. There are some of the studies which have compared the results with the bilateral cataract surgery as well as the single eye surgery. This results say that the simultaneous bilateral cataract surgery did not lead to any increased incidence of intraoperative or postoperative complications. So the visual acuity results were also good and the patient were pleased. So no complication was observed that could be attributed to the procedure being done bilaterally. The risk of endophthalmitis again has been seen in bilateral cataract surgery. The risk is really not there. So risk of postoperative endophthalmitis was not statistically significant different between the patients who underwent the immediate sequential bilateral surgery and a DSB CS surgery or a unilateral cataract surgery with a gap of about 4 to 6 weeks. Now, when we plan to do bilateral cataract surgery, there are certain guidelines which have to be followed. An experienced surgeon with good safety record should be the one who should be performing a bilateral cataract surgery. Each eye should be treated at an individual eye. It means that we use a separate sterilization trays and instruments. And some people prefer to use intracameral antibiotics so that you take care of the endophthalmitis, but this is an individual preference, not must for the patients. And eye patching should be avoided if we are doing surgery under topical anesthesia. Antibiotic drops because should be started as early as possible after the surgery. So thank you very much. So it's a time for the new attitude to simultaneous bilateral cataract surgery, because we see from the literature that the risk of complication is same as we talk about unilateral cataract surgery. Thank you very much.
Thank you, Dr. Bansal, and I think we've just completed on time, and I would like to conclude this session, and special thanks to Professor Pandav sir for sparing time and all our eminent speakers for being so precise and giving such wonderful talks. Thank you, everyone.
Thank you. Thank you, Dr. Diksha.
Thank you, Dr. Diksha, for moderating this interesting session. Thank you. Thank you, everyone.
Thank you
very much. Very nice session.
Yeah, thank you. Thank you. Thank you. Thank you.